they multiply. Okay, they're carrying from the blood is infected first liver from the liver. Ultimately, it first infection the liver cells. From there, then is going to the RBC. Mainly, we are concerned with the RBC. They develop from the egg to the adult one in the RBC. That's why the whole RBC is destroyed. See how it multiplies in the RBC, then gamete, then this is microgamete, then is became the big one and going there, releasing here and again against the cycle. So mainly it use the RBC. That's why the reason we have to take the EDTA blood. They are showing it. We are going to show you how to do the smear. So it said, whenever possible, use separate slides for thick and thin films. Don't use the same slide. Thin film, bring a clean spreader slide held at 45-degree angle. The angle should be more for the thin slide towards the drop of the blood on the specimen side. Thin plate wait until the blood sprays along the entire white. So when you are touching it, we are going to show it. When you are touching it, the drop, so that the blood is going to spread here totally. Then you spread it. While holding the spreader slide at the same angle, push it forward readily and smoothly. So then you are going to, you touch, first you are putting the drop. This is called the spreader slide. This is the slide where you are going to make the smear. You are holding the slide at 45-degree angle. Then you are touching the blood drop. When the blood sprays throughout the white of the slide, then you are going to spread it quickly but smoothly, not with the jerk or anything. If you do the jerk, smear is going to be wrong. So you have to forward or to push the slide at 45 degree. So why I'm telling you for 45-degree angle for the thin slides. Now you have the thick film. Using the corner of the clean spreader slide, space a drop of blood in the circle of a size of a dime. That is 1 to 2 centimeter. You need a big blood drop here. There is a small blood drop, it's a big blood drop. Do not make the smear too thick or it will fall off the slide. You should be able to read newsprint through it. Wait until the thick and thin films are completely dry. Fix the thin and thin film with 100% absolute methanol. Do not fix the thick film. Only the thin film you are going to do it. We are not going to do it in the lab here. Just you have to know for the exam purpose. Even you are not going to do the slide probably in the lab. And if it's lab, they are going to tell you how to do that. And it's more now. So only the thin film you are going to fix with the 100% or absolute methanol, not the ethanol or isopropyl alcohol. This you have to thin film for the malaria side has to be fixed with the 100% methanol or called the absolute methanol. Do not fix the thin film. The both thick and thin film must be made on the same slide. Same slide means same company slide, not one in another group of slide, one is from the another. So same slide means not in the same slide, but there will be two different slides, but they should be same company, same category of slide. When the thin and thick films are completely dry, stain them. Things, thick smears might take 1 to 2 hours to dry. Protect unstained blood smear from excessive heat, moisture, and insects by storing in a covered box. So malaria, how it looks like here. You can see something here. You see here. This is the RBC, right? RBC should not have all these things. So you can see this is the malarial parasite, Plasmodium vivax. So they are now more. Okay. This is how it looks like the peripheral blood smear film. When it goes, at the end is going to be the feather edged. You are going to learn that one. Peripheral blood film smear. Sources of blood for the blood film. From where you are going to get it? You can get from the EDTA tube, or you can get it from a finger or heel puncture. Can be used also. Only the drop of blood should touch the slide, not the skin. Only the drop of blood should touch the slide, not the total skin when you are taking it. If the blood is collected in EDTA for morphological study, the film should be prepared as soon as possible, certainly within 2 hours. So this is another question. For making the malarial blood smear, if you are getting in the EDTA tube, it has to be done within 2 hours or as soon as possible. And you have to mix the blood. Whatever I am telling, take notes. So basically, this is already done. We already described how you are going to do a peripheral smear. First, you have to wipe the slide with a lint flea cloth or the lens paper. Place the frosted side up, as I told you. That is the working surface. Then you have to label the slide. Then you have to mix the blood specimen gently by inversion 3 or 4 times when you are taking from the EDTA tubes. Then either you can insert a needle device on the top of the stopper, and then you can use this one as a, sorry, like this one. You have that one in the lab, right? You can just drop the blood. You guys used it? Did Saina showed you?
No.
No?
No,
So
yes, ma'am.
okay, so this is the dropper. So you can just, the tube is intact, so you can press this one, and if you just put the tube, it's going to give you 1 drop of blood. Okay, or if you don't have this one, don't worry. So you are going to invert it, and then you are going to use the capillary tube, the blue capillary tube, and you can take the blood as you are doing for the blood grouping. You can take that one too, and then ultimately you can place the blood in the slide, and again hold the blood tube at 45-degree angle and insert a capillary tube. That's why it hold 1 to 4, 1 to 8 into the blood. Allow the blood to rise until the capillary tube is 2/3 full. That you guys know how to fill the capillary tube. So that's why I'm going speaking fast, right? You have to hold the tube, not straight. Remember, I told you sometimes you are taking the blood, putting the tube in the straight. That's why I told you when you are doing the mitohematic, place the EDTA tube at 45-degree angle and then insert a capillary tube, and then the blood will come nicely. And when it's 2/3 full, that is for the hematocrit also, then you can take it out and place a drop of blood. This is very funny. Gently replace the blood specimen into the rack. Wipe the capillary with a tissue and touch it to the slide about 1 centimeter above the frosted level. So this is, if this is the frosted end, 1 centimeter above means you have to move away from the 1 centimeter. Frosted level, lift your finger up the top of the capillary to allow a drop of blood out at 3 millimeter in diameter or small one. Put your finger back. These are not going to come question, and you are going to learn it. When you are going to do it, you can understand much better than I'm telling it. Put your finger back onto the capillary and discard it into subcontinence. That you are doing it the mitohematocrit, right? You can understand what is written here.
Yes.
yes, ma'am.
Okay, so then angle the slide on the counter to allow the spreading motion to be comfortable. So that's we are going to learn it. So angle the slide on the counter to allow the spreading motion to be comfortable. How we are going to do it. How we are going to angle means how we are going to place the slide. Sometimes somebody can do it when it's straight. Like I prefer to do it straight. Somebody like to have in the angle. So it is your expertise and your experience and your techniques. We are going to show you how to do that. Then how you can do the best, you can figure it out. Steady it by pressing on the frosted end with the little finger or forefinger of your non-dominant hand. Hold a second slide. Hold a second slide firmly between the thumb. These these are not going to come in question, but you are going to show how you are going to do that, or we can see the video. Instead of reading this one, go to the picture. So this we already described, right? This is the frosted end. You are going to write it. Then you are taking the blood from the EDTA tube. You are shake 3-4 times to evenly mix the tube. Either using the top dropper, you can put the blood here, or with the the capillary tube, you can place a drop of blood here. Then you have this hand. With the right hand or your dominant hand, what you are going to do, you are going to touch the blood. And when you touch the blood, it's going to spread like this. It has to be very quick. You are telling this one, otherwise the blood is going to be dry. And then you are going to try to push this one. When you are doing this, it's better to hold the slide in by this one by the left hand or non-dominant hand. See how they are doing it? They are forwarding the blood to make a smear. Characteristics of good smear: be about 3 to 4 centimeter in length, progress evenly from thick to thin. So because you are going from here to there, it should be thick here and then to be thin here. You can see thick here and thin here. And it has to have a tongue-shaped appearance. Be bullet or rectangular shape. A rectangular shape is said, or bullet. Have an adequate sized monolayer. Have an even WBC distribution when viewed microscopically. How you are going to understand? When you are going to see under the microscope, you can see even layer of WBC, not the thicker. So it should be thick to thin. It's not going to be thick, thin, one like this. There is a holes, air bubbles like that. No. Have a thin edge with free of trails or nicks. So this is called the free edge. There should not be any streaks or anything. It should be smooth. Not extended the edges of the slide. It should not go out. It should complete between inside the slide. Not have ridges, wavy lines or holes. That's I told you. When you are going to do it, you will see. If you doesn't clean the slide, if you doesn't have, you will see lot of wavy things, lot of holes, air bubbles. So that you have to practice. Sources of error: too large a drop of blood makes smear too thick, except for the malaria. Too small drop of blood, smear is too thin or short. Spreader pushed with inconsistent pressure. So that means when you're pressing the pressure, it should be in a same pressure. You cannot start with the high pressure, then release it. So inconsistent pressure, chattering or ridges, smear is poorly shaped with jumps. Increased angle, more than 25 to 30 is thicker smear. If you increase the angle, decrease the angle, thinner smear. So what is the angle for spreading the slide? 25 to 30. For thicker smear all in the blood, that's 45-degree angle. Spreading motion is too fast, thinner smear. Spreading motion is too low, thicker smear. Too much pressure on the spreader What happened? WBC accumulation in the edges and tail and distortion of the cells occur if you give the too much pressure. Dirty, greasy slide, streaks under holes. Slide with a chipped or unpolished end, streaks or lines, blood drop visible, did not use whole drop in the smear. Let dry before spreading. So you can see. This is the perfect one. This is too short. These are the streak. This is the air bubble. This is the one-sided. It doesn't spread the whole here. Okay. This one out of the slide. Here the drop is like this. It didn't spread properly. So you have to spread it and then you have to do that one. You can see thick to thin smear. This side doesn't reach the 2/3 of the slide and this is not acceptable. So you can understand you all are going to make this type of slides at the beginning. These are the non-corrected one. It takes long time. Some people can do it very quickly, but in general, from my experience, students fight a lot in making the blood smear. Okay, staining procedures. Staining options, quick stain method. We have two-step method. Dips may differ based on the site. Automatic stainer, what they use, Siemens Hemax stainers. This is the they have the nowadays they have automatic stainers, but before in lab you are going to do it using the staining jars. What are the automated stainer? Hematec is an example of an automatic stainer which stains the smear by capillary action. This Hematec stains the slide by what action? Capillary action. Okay. The smear moving face down along with a platen or platform triggers sensitive switches to activate the solution pump. So emitter, you doesn't need it. Slide instrument platen doesn't. Only the Hematec method is the automated stainer and use the capillary action to stain the cells or the slide. So this is, they have all the things. This is the Hematec stain pack. We don't have this machine in the lab. We are going to stain with the jar. Romanowski type of stain. Consider neutral since it has an acidic dye and a basic dye. What is the neutral stain? Romanowski stain. Okay, so this is, you have to remember, neutral stain. Neutral means it's not acidic, not basic. So it's a neutral. pH, what is the neutral skin means? What is the pH?
pH 7.
pH 7.
7.
Good. Good. pH 7 is the neutral pH. Because this dye has two components. One is red color, eosin, that is the acidic, and it has a basic dye, the methylene blue. So that is the basic dye. So reticular stain is the basic dye, right? Because it has only the methylene blue. And Romanowski stain, you have to remember these stains names. So Romanowski stain is the neutral stain. Dye imports color to the cellular components are attractive, and types of art dyes include Giemsa stain, rice stain, and this May Grunwald stain. So you have to remember what type of Giemsa stain. These are all called the Giemsa stain. One of the component of the Romanowski stain is the Giemsa stain, rice stain, and Mary Grunwald stain. So rice stain, in general, we call the rice stain, is commonly used for staining blood smear, mainly the different type of blood cells. Contains methylene blue or azure B, the basic, and eosin and acidic, and it has the fixative as methanol. So this dye is dissolved in the methanol to do the staining. So how we do it manually? First, slides are flooded with stain, left for 1.5 to 2 minutes. Solvent stain is a methanol, whatever we told you. Where you are dipping it is a methanol, and methanol acts as a fixative. If not staining right away, fix with methanol. Add equal amount of buffer, whatever have the sodium phosphate, to the slide, then allowed to sit for 3 to 5 minutes. Metallic sheen forms on the surface because it has the methanol. When you are putting the PBS, is the water or the buffer versus the alcohol. Then you can see some metallic sheen. Till the slide to dump stain buffer mixture, reach gently with buffer, wipe underside of the slide and allow to dry. So basically you dip it or you flood it, the slides with the stains, then you are going to leave it for 1 to 5 minutes. And then you are dipping, this you are going to learn it, then you dip the excess stain off, and then you are putting the equal amount of buffer, like the sodium phosphate buffer, to slide and then allow to sit for 3 to 5 minutes. And then you dump up that one or throw out that one, and then rinse gently with, again you are going to, because the excess stain is going to out, right? Then rinse with again buffer and then wipe underside of the slide, because the stain is going to be the underside. If you doesn't clean the underside, then what is going to happen is going to give you more dark stain, you cannot see anything. So staining problems, too blue, excessive blue staining of the cells or failure to stain the eosinophil cells components may be caused by stain and buffer pH is too basic. So that's why if the buffer pH, it should be the neutral pH. If it is more high pH, by any chance the pH was not adjusted properly, that means it's going to take the more blue stain, which is the basic dye. Staining time is too long. Instead of 1.5 to 2 minutes, if you put it 40 minutes, 5 minutes, or the smear is too thick. And pink, when excessive of eosin stain or the buffer pH is too low, then it's going to call the excessive pink, or the staining time is too short. Staining problems, excessive light stain. All cell components are understained. If you have light stain, may be caused by staining time too short, washing is too long or vigorous, and improper stain to buffer ratio. Artifacts, stain precipitate present with when viewed microscopically and may be caused by, what are the artifacts? Stain solution requires refiltering. Sometimes even you are seeing the staining looks like the liquid, but sometimes there are some, what is called, how am I going to, so when you're putting the dye, maybe it didn't properly went to the solution, or if you save the dye, what happens, sometimes it settle down some precipitate. So all these things can come as an artifact. And as those are in methanol, those are going to be fixed with your smear. So that means when you see all these artifacts, you have to filter the stains. Use of too little stain solution during staining. Some of the stains evaporated down to the onto the smear. So instead of bathing in the dye, if you are put less amount of, that's why you have to dip the slide and take it out. Then it's going to, what happen, the stain became evaporated. Washing is inadequate in amount or not performed vertically. So washing has to do with the vertically. Microscope examination of the peripheral blood film. You already had learned about the microscope before when we did the instrument. So here all the questions may come here in the hematology. What is the objectives, what is the how you are going to, what is the eyepiece, what is the nose piece, what is the iris, what is the condenser, what is the adjustment screws, the coarse and fine, what is the stage, how you are going to move the slide. So these again you have to remember. What is the oil immersion, what is the different power, how you are going to calculate the total power of the microscope, what you are seeing. If it is 10 and here is 10, what is going to be, when you are going to, what is the lower magnification, what is the lowest magnification we use in the nose piece?
It's 4.
Lowest 4. And when you are seeing the object, if the eyepiece is 10, that means how much is getting amplified?
40.
How 40.
40.
So eyepiece times the nose piece, right?
Yes,
How
ma'am.
is the, what is the power of the oil immersion?
100 x.
Ultimately, we are seeing the
100.
ultimately how enlarged you are seeing. What times?
1000.
1000. So you can
1000
understand
times.
everything is you needed to remember. Everything is related from here to there, there to here. So smear review is done to obtain an overall impression of the white blood cells, red blood cells, and platelet population, and to verify instrument result. So right stained blood films are examined microscopically to differentiate and count the relative numbers of the various types of leukocytes. Various types of leukocytes. When you count the different relative numbers of different types of leukocytes, what is called?
White blood count.
No. White blood count is the WBC count, the leukocyte count. When you are counting the relative number of different or various types of leukocytes, what is called?
Differential
Differential.
count.
Differential count. Differential count. So estimate the number of, and then to estimate the number of platelets, leukocytes, and to assess the report WBC, RBC, and platelet for nowadays. You used to do that. You used to train and do that in the what is called in the slide. Nowadays, everything is done in the automated things. Microscopic examination of the platelet flame by MLTS. Examination of the erythrocytes for alteration and variation in the morphology and color. Right?
Yes, ma'am.
Give me one example where you see the difference in the morphology. Normal versus abnormal.
For the erythrocytes, ma'am,
Yes.
polychromasia, like they are not stained, they're pale.
Yeah,
Because
I'm telling the morphology.
In morphology, in the
Oh.
malaria parasites.
No, they're smaller in size.
Malaria
RBC.
parasite,
there
you
is
can
a
malaria parasite, you can see the difference in the morphology. You can see the inside.
Yeah.
Morphology
And
means
yeah,
outside.
they're,
It's
the size is
morphology.
microcytic. Sizes of the
Morphology,
RBCs are microcytic.
I guess my
okay,
morphology,
sickle
if
cell
it's
anemia.
biconcave or sickle cell.
Sickle cell.
Sickle cell anemia, yeah.
Sickle cell is the totally crescent shape. You can see the structure. It's the biconcave one and the sickle cell. Very distinctly you can difference between the sickle cell and this one. And other things, anisocytosis or big or size, there is a difference. That is the morphology also. But very distinct. This is a very common example, very distinct example. Sickle cell anemia. It's a totally different in shape. Okay. Estimation. Sorry, I just ask you the questions so that you guys can take it out from your heart and the brain so that you guys can remember. So estimation of platelet count and evaluation of morphological changes like the size, clumping, differential, if the high platelet count, if it's the low platelet count, what is the high RBC, if the what type of MCP, hemoglobin, everything, and differential count of the leukocytes. In general, you have to count 100 cells to give the differential count, to give the percentage. Examination of the leukocytes for morphological alteration. Okay, so erythrocyte alteration. Different characteristic note, variation in color or staining reaction, variation in the size is called the aniso. Now, this terminology you have to remember. What is the variation is the size is anisocytosis. Variation is shape is poikilocytosis. From the anisocytosis, you can have the micro or the macro. Okay, but aniso means variation is size, and when is the variation is shape, is called the poikilocytosis. Note. Variation in the structure and inclusions, artifacts, abnormal distribution patterns, presence of nucleated red cells. If there are too much nucleated red cells, that means what is happening? What it will tell?
Polycythemia, right? Like production of more red blood cells.
Yes, nucleated red cells. There may be polycythemia. When
It's
there is
too
too much
Yeah.
presence of too much nucleated red cells. No, sorry.
So too
Sorry.
much young, immature red blood cells.
Immature red cells. So I am just saying you confuse me. Too much red cells. Too much red cells is polycythemia. Okay.
That's right,
But
ma'am.
when there presence of nucleated red cells, that means patient is a high anemia because they
Yeah.
are trying on the pull the reticulocytes who didn't get time to be mature to get rid of. They are the immature reticulocytes are coming in the peripheral circulation for the anemia.
And they're
That is
common
the
also, ma'am, in babies, the nucleated
yeah.
RBCs.
The babies are different because they are always getting the maturation, right? Within the
Yes,
5 years,
ma'am.
everything is settled down. But in general, if you see the presence of too much nucleated red cells, means that is the reticulocytes. Because red cells doesn't have the nucleus.
Anemia.
Red cell doesn't have the nucleus. So it's a tricky thing that is telling nucleated. Oh dear. Nucleated red cells means there is a chance of anemia. Okay. We have some more. Yeah. Okay. Staining reaction. Hypochromatic when is less color. Hypochromatic means color. When is hypochromatic is less color. Hyperchromatic is the high color. Variation in the staining color when is pinkish blue is called polychromatophilia, or polychromasia refers to the RBCs that's a faint blue or blue orange color with rice stage. Polychromasia refers to so faint blue color, which is giving you the cytoplasm faint blue and blue orange color with the right stain. Okay. So this is when I already told you, when difference in the size is called the anisocytosis. Aniso And anisocytosis can be two: macrocytosis when are bigger than normal, and microcytosis when is smaller than normal. I already told you. Variation in erythrocyte size. This is the anisocytosis. So when microcytic, this is the normocytic, when it's a normal, is called the is whole. All of them is under the difference in size is called the anisocytosis, whereas the normocytic is anisocytic or macrocyte. So this is the micro. When is smaller, the cells are smaller, is the microcytic. When is a normal, is called the normocytic. Macrocytic, when is a larger, the cells which have the malaria, they appear as macrocytics because the parasite is inside them. One example. Alteration in the shape is called the poikilocytosis. There are different type of shapes. When it's like the star, is called the acanthocytes. I cannot remember all this name, but you can remember a couple of them. You have to remember. I am telling you, this is called the. This is each one has. This is called the crenated. When the RBC surface like the wrinkled outside is called the crenated RBC. In general, the RBC looks like the biconcave shape. Okay, discocyted like a disc. Then you can see the sickle cell anemia, how it looks like. It's very distinctly differentiate. Spherocytes, when they lose the biconcave shapes, it became the round. It's called the spherocytes, which generally comes in question. I am going to tell you. This is the acanthocytes. This is also comes in concept. And then blood cells doesn't come that much. This is the cystocytosis. It looks like the different shapes. Target cells are like this, and teardrops, it doesn't come that much question. Now, what is When you are learn the ESR, did Saina told you what is the Rolex formation means? Or you already learned the ESR, right? When Saina teach you?
Yes, ma'am. We have already prepared ESR.
But did she describe you what is the Rolex formation?
No, not yet, ma'am.
So when you learn the ESR, they didn't know, she didn't tell you what is the Rolex formation, right?
She actually learned, she just did a practical, like a preamble. Just that practical was like a preamble. She didn't go in depth.
Yes, that's right.
I talk too much, right, in the class, in the practical class? My God. Maybe you guys are upset for that. I am just joking. I'm joking. I'm joking. I'm joking. I'm joking.
It's okay.
I am joking because I know where there is a problem. That's why you should tell you. So Rolex formation, these questions come too often, okay? Abnormal cell distribution. Rolex, when this is the abnormal distribution of the patterns of RBC. When the RBCs took together or become aligned and aggregates that look like a stack of coins. That happens when there is a problem. So when you are doing the ESR, you can see it's some RBCs like stack of coins in the down. Generally, you will not see it in our blood, but sometimes you can see. So what happens? The RBC should be floating, right? But they stick together like one coin after one coin. That is called the Rolex formation, okay? Agglutination, this is irregular or amorphous clumping of the blood cells. When it happens, you know blood grouping. When you put the antigen, antigen, when you put in the blood group, if it is A blood group, is antigen is going to anti-A means is going to fight with the A group, A antigen. So that's why you have learned about the what the agglutination means. Peripheral platelet. Platelet is the platelet has a nucleus?
No.
Let's have fragments.
This is the
Fragments of
fragment
the
from whom? From where it comes out?
megakaryocyte.
Megakaryocyte is pinch up from the
Yeah.
megakaryocyte
Bone
and
marrow.
acts as a platelet. Okay. Platelet estimation. I can hear probably 2 or 3 people's voice, but everybody understand that? Or if you stay quiet, you are going to lose it, not me. Participate. Then you can understand. Platelet, we just learned it yesterday. Platelet estimation means platelet count and also the morphological changes. What is that? Perform the difference count of white cells. Difference count means exactly we know we count the different types of cells. What are the different kinds of cells of the white blood cells?
Neutrophils.
Neutrophils,
Most commonly.
basophils.
Eosinophils. Lymphocytes and monocytes.
Okay. So we count the each one, how many are these? That is called the differential count. So what happened? In cases of leukopenia, only 50 cells need to be counted. And the differential percentage will need to calculate. This you doesn't need.
Excuse me, but when you say count, are we actually going to count them one by one, or is there a way they get counted? Like when you say count 500
See, nowadays
cells.
automated cell counter counts it. But before you used to count in the field, because when you are seeing under the microscope, you can see field, and then you are moving the slide with the stage. And you have to count the
You're
100
counting it
cells or
one
50
by
cells.
one.
Yes, in one field. Whatever you are seeing through the microscope, there is a field, right? You get the round field.
Thank God
You are
for
going
automation.
you are going to count probably. You get only WBC. Maybe you get 10
There is
of them.
that
Then you
count.
have to move to the another. So you have to count minimum 50 cells or 500 cells through the enter slide. Through the enter slide.
Yes, ma'am, per 100 WBCs.
Yes.
And there is
Yes.
that counter.
Yes, you
counter
have to
that
have
I
the
have
counter and you
always
have to
learned.
read tick, 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 tick. We used to do
Yes,
the
ma'am.
counter. Yes,
Yes,
yes.
ma'am.
We learned it. We learned it in the here. Nowadays, there is automated cell counter. Nobody does that. The blood cells goes through that automated cell counter. And did you learn it when you do the LLSP about the cell counters?
No, ma'am.
I think you guys did it. Automated cell counters. Because I saw the questions there.
Just only for the measurement of the hemoglobin, the ESR.
No, no, no. When she took the online class,
Oh,
not
the
the
online.
practical.
No, sorry, ma'am, I don't remember.
How the automated cell counters work.
Automated the cell
No, no, no.
counters.
I don't think we have. I can't even remember hearing that automated
Yeah,
cell count.
Me too.
we did not.
Count all these counts.
Okay,
Amina.
maybe in this chapter. I don't know. Because I didn't do the teach the unit number from 11 to 20, right? She teach it.
Mhm.
No, 11. Yes, 11. I did up to that. Yeah. Then I left. Then she teach on online, right? So I have no idea what was there. I didn't read it also. And my mom was so sick. I didn't able to. Only I send you the reviews. I worked on that.
Yeah.
Okay. So anyway, persons with limited training in hematology should not attempt to identify abnormal WBCs. Obviously, you need that one. So microscopic examination of the peripheral blood film continues. What is the clinical significance of erythrocyte alterations? Clinically, alterations in erythrocyte morphology are associated with many diseases, especially with anemia. Morphology. Now he's coming the anisocytosis and the shape. Anemia is not a specific single disease. It's a condition. I told you yesterday again. Anemia is a condition in which there is a decrease in oxygen carrying capacity of the blood. So how you that is question. Anemia, they are going to the option either low iron or oxygen carrying capacity of the blood that results in the decreased oxygenation. What are the causes? Maybe there is a problem in the total number of RBC. Maybe there is a problem in the iron loading. Maybe there is problem from the different structure like the B12 Pacinius anemia, which helps in the production of the combination of the hemoglobin to the oxygen or iron molecule to the heme or iron molecule attachment to the globin protein. It can be caused at anything, but ultimate problem is the decreased oxygenation and the decrease in the oxygen carrying capacity. And when it's decreased means body tissues and cells get decreased oxygen. And you are going to feel fatigue, you are going to feel lethargic, you are going to shortness of breath. So it has many causes, and this type of anemia and its underlying cause must be determined before treatment and can be eventually undertaken. Leukocytes. Leukocytosis means generation, cytosis means generation of the white blood cells. So when it's above normal, it's called the leukocytosis. Penia means low. So leukopenia is low, below normal count. Anything high or below is above normal or above below. Quantitative changes in any of the cell types are described by the following terms. Neutrophilia means increase. Neutropenia, this we have already discussed yesterday. Neutropenia is decrease. Eosinophilia and basophilia. Why there is no pinia for the eosinophilia and basophilia? For the basophil and eosinophil?
Because there are
Their
all
quantity are
already low
just so
numbers.
small.
Very low number. So sometimes they are no present there. So you cannot tell that means penia, right? But obviously, if there is any eosinophil, is responded to for what? When there is a high rise of eosinophil.
Parasitic infection and allergy.
Parasitic and allergic reactions.
Basophil?
Allergic.
Histamine.
Okay.
Yes, histamine.
Histamine. Okay, good. Very good. And then you have lymphocytosis. That is the lymphocytes. Lymphocytes are responsible for
Viral
mainly,
infections.
yeah,
Viral infections.
viral infections. That is the mainly the antigen. The antigen and antibody production is the lymphocytes. And the immune system, immune cells, lymphocytes. And it's a mainly viral. And bacteria, main bacteria, who does take care of the bacteria?
Neutrophil.
Neutrophil. And monocytosis, monocytes, what they does?
Or inflammatory.
Any kind of inflammatory, any kind of bacteria, virus, monocytes go anywhere and they phagocytosis, kill the cells.
Yes.
And how it works? The WBCs, if the infection is some another site, how the WBC do the protection? Or
Diabetes. Diabetes.
what is that diabetes?
Yeah, they can migrate.
They
can
migrate
migrate
from the
from-
blood
From
circulation
the, yes,
From the blood to the
vessels
tissues.
and go to the site. So they slick through
diabetes, right?
diapedesis. Yes,
Yes,
these
diabetes.
questions comes. That's why I'm just trying to review it and so that refresh your memory. So how Amina is responding, I want everybody to respond. Like the Evelyn, I can hear Evelyn's voice also, not anyone else. I can hear only the two people's voice. I want you others also to participate, to give the answer. If you doesn't speak, how much you hear, you will not memorize, because when you try to tell the answer, the whether you are memorized or not, it comes out. Only writing the notes is not going to work. You have to speak, you have to talk, you have to participate in the class. Okay, malarial. Parasites red blood cells. Parasitize means when the blood cell is infected with the parasite. Mainly the red blood cells is infected with the malarial parasite. So various stages of the malarial parasites may be seen in the erythrocytes in the blood from the patients with malaria. What is the different stages? Because they are growing, right? From the, say for example, from the fertilization is not the unicellular organism. It doesn't look like that, but just for giving an example, like a mother wombs to become a baby, the total cycle in that from the fertilization to the make a baby. So there are different stages. I am not telling you all the stages. It's going to be spherozoid, tropozoid, different type of stages. But that's why all the types of stages can be seen in the inside the RBC. That is called the various stages of the malarial parasite may be seen in the erythrocytes in the blood from the patients with malaria. Depending on the species of malaria organism present, the parasite may be confused with other artifacts, inclusions affecting RBC. So it depends on the species. So how is that? This is the hemocytometer. We used to use this one. Evelyn probably knows that. This is the
Yes, ma'am.
hemocytometer.
Yes,
Here
ma'am.
we used to do the cell count. Now it is automated cell counter. That's all counts.
Yes, ma'am.
Yeah.
The four corners are the for the WBCs.
Yes. We used to do this one. Yes, to WBCs also. So then this is called the hemocytometer. There is an area where there is a square, different type of measurement things. And then you are going to put the slides and you are going to put a drop of blood and then you are going to see the cells. So this is the hemocytometer, loading a hemocytometer. What you can do, body fluids, oil mix, blood, oil mix, samples may need to be diluted with diluent proper to loading the tube or able, because it is too thick, it's going to be overlapping. So sometimes if it needs to be diluted the sample and then you can multiply with the factor how much you diluted. Blood specimen may need to have RBC lysed for doing the WBC count. If you are doing the RBC count, it's okay. If you are doing the WBC counts, that time you have to hemolyze the RBCs so that the RBCs cannot be any contributing factor prior to loading if you want to count WBC or platelets. Body fluids you can count CSF, pleural fluids, peritoneal fluids, and any kind of fluid and more. Synovial fluids, what is the synovial fluid? From what it comes?
Between the knee, joints in the knee.
Any joint,
Joint.
yes, any
Yeah.
joint. Pleural fluid,
Lungs.
In the
lungs.
pleural cavity.
Yeah,
Lungs,
pleural
yeah.
cavity, there's the lungs, and yeah, and peritoneal fluid.
Peritoneum of the
Is near the
abdomen.
abdomen. Good, good,
Yeah,
abdomen. Yeah,
abdomen.
good, 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 good. Always ensure original suspension is mixed well before taking the, always mix the sample. That I am telling you every time. An appropriate dilution of the sample is needed to perform an accurate cell count. If it is too much thick, you have to dilute it. So first you have to try the original sample. If you think is too much, the cells are overlapping. So then you have to dilute the sample and then recount it. And then if you do 1:1 dilution, then you have to multiply the results with the factor, how much you diluted it. Hemocytometer, developed to count blood cells manually, has two chambers with a microscopic grid etched on each glass surface, overlay chambers with glass cover seal, tip of the pipette is placed. I'm going to show you. B-separate in group to load the sample. So this is the hemocytometer. This is the grid is there. There is the cover slip, you are going to put it both side and you are going to put a drop of blood or any fluid and then you are going to count here. So this can be reusable or disposable. Generally we used to have the so this is the grid. You can see this one. This one has the grid here and in this grid there are 4 big corners and one with the medium very small corners. So this is the area we count. Common challenges: if sample is not mixed well before loading, misinterpretation of cells in specimen can lead to the inaccurate cell counts. So I always tell you, inaccuracy due to human reading counting. Count both sides of the QC purposes. So when you are counting, generally not only one side. We take the same sample and we count in both sides to the quality control purpose so that there is no human error. Clean properly to avoid cross contamination from previous patient. If you are not using the disposable one, if you use the glass one, you have to clean it properly so that there is no contamination from the previous sample. Evaporation if not placed in damp chamber after loading. So you have to use it, the damp chamber. If you have to keep it, if you're immediately counting is fine. Pipetting errors. Avoid overfilling the chamber may give inaccurate. If you just So if you feel there is, you have to put one drop. I can see it slowly go and spread. If you overfill, the cells are going to be too much. If you move the slide, the cover slip, not the slide, cover slip after loading is going to give you error. So this technique is very in the ESR. You guys did this one. This is the, it said, phlebotomists draw the blood in the tube, test measure how fast red blood cells fall into the bottom of the tube in an hour. So that is called the sedimentation rate. Microhematocrit is the red cell packed volume and ESR is the sediment, how the blood cells, how faster the blood cells can settle in the bottom of the tube in an hour. That is called the rate. Sedimentation means how it can sediment. Inflammation causes red blood cells to stick together and shrink faster. So when there is inflammation, it is going to stick together and sometimes it's from the Rolex also. This is one is sticking with another. You can see this is the Rolex formation. When we stack up coins like this, it's called the Rolex. Okay. This is the Rolex formation. Rolex formation is determined by increased levels of plasma, fibrinogen, and globulin proteins. This is the ticking. ESR reflects mainly changes in the plasma proteins that accompany acute chronic infection. In such situation, ESR levels are much greater than 20 millimeter per hour. And this is when the RBCs stick each other and doesn't move. Generally, the erythrocytes moves like this. When they stick, they are thick and then they sediment very fast. So that means more higher sedimentation rate means you have more inflammation or any problem. ESR samples. What type of samples you need? You need the whole blood, EDTA blood. Can be either EDTA or sodium citrate tube. You can take it from the lavender tube or even you can use the blue tube. It depends upon. Ensure no clots. No clots should be there. Fresh is the best. Can collect in dedicated ESR tubes. That is the sodium citrate tube. Nowadays, we doesn't use it. We use the EDTA tubes, but you can use it because Western green tube uses sodium citrate as an diluent. Can be manual or automated test. Nowadays, everything is automated. So you have this, the rack for standing the ESR tube, right? Before you used to stand in the tube. Nowadays, you have the another one, the vial, where you are diluting and then you are putting this one. Before you used to read it like this, hold the tube like this. So ESR significance, more specific screening test for inflammation, mainly inflammation. When there doesn't get any problem anywhere, RBC count, WBC count, nothing is there, then they ask for the ESR to make sure whether there is, why the inflammation or why the problem, why the joint pain is coming. So ESR increase in rheumatoid arthritis. We all have. Rheumatoid arthritis is an RF is an what type of disease?
Bone disease.
It's autoimmune, ma'am.
Autoimmune disease. And osteoarthritis is the wear and tear of the bones, right? When the bones become, there is a problem in the hormonal disbalance, calcitonin versus PTH. So bones become fragile and it's getting eaten up. So ESR will increase in rheumatoid arthritis, is the systemic lupus erythematosus or lupus, inflammatory bowel disease, acute myocardial infarction, heart attack, and other any inflammatory condition. So this I cannot remember before that acute MI increased RF, ESR. This is they have added it. I didn't know that for the heart attack ESR increase. But the heart attack test they doesn't do the ESR test. There are so many other tests for check the heart attack, so it doesn't do the ESR for the heart attack. But yes, heart attack also can change the ESR level. So rate depends on the following: the number and size of the erythrocyte particle. Heavy is going to go first. Microcytosis is going to go less. Plasma factors because they are floating there, depending that the plasma proteins are there, which helps to either they become, if there is a problem in the RBC, they become stick together, or they can free flow and go down. Certain technical and mechanical factors. So obviously that is calculated in hours. Erythrocyte sedimentation rate, these value has to remember, it goes to come in exam, in practical. So how you do that? Units millimeter per hour. What is the hematocrit? How you express the hematocrit?
Percentage.
Percentage. And you have to remember the microhematocrit value is higher in mitochondria value is higher in
Male.
Polycythemia.
male and low in
And male.
female. The ESR is just opposite. It can
Yes.
go 0 to 20 millimeter per hour, and male normal is 0 to 15 millimeter per hour. Okay? Okay. So there are two types of methods. Probably she already told you, right? Two types of ESR methods. We can
Yes, ma'am.
yes, yeah. Winthrop and Winston Green. Did Shaina told you the difference?
She showed us the Western grain tube. She said the other tube was not available, so
Both
she didn't
actually.
talk much about
No, but she teach it, right? The what is
Yes,
the
ma'am.
She
difference
taught
in the
with the
class?
Western
What
grain.
is
The
the
Winthrop is the glass tube.
Winthrop is the glass tube and Western is the both can be glass, both can be plastic, disposable. But nowadays everything is disposable. But whatever we have, the Winthrop is the glass tube. So only the main difference of the Winthrop and Western Green, these questions is going to come. Winthrop tube, the blood is EDTA blood. Tube is smaller in diameter and length is only 100 millimeter. Whereas the Western Green tube is 200 millimeter long and you can take the sighted blood. So when the shorter column makes the test less sensitive, shorter column is 100 millimeter. So that's why nowadays it has been used the Western Green because it's 200 millimeter long and it can give you the better result. So shorter column makes the test less sensitive. So Winthrop tube is less sensitive as it is shorter in length. That's the thing. Okay. And Western Green tube versus this is traditional is what is 3.8% sodium citrate. This is the Winthrop versus Western Green. Traditional 3.8% sodium citrate if vacuum tube, no dilution needed. So this is we are using in no dilution needed. Modified EDTA needs dilution before testing 2 ml EDTA with 0.5 ml of 8% NaCl or sodium citrate. What you are doing in the Western Green tube, right? You have the diluent, right? You are mixing it and then you are
Yes,
putting
ma'am.
the tube. So that is the dilution. So larger tube than the Winthrop tube. So this Winthrop is 100 millimeter and Western Green is 200 millimeter long. Western Green we are using the sodium 3.8% sodium citrate with the diluent. Whereas the Winthrop tube there is nothing. You can directly use this one. ESR testing errors. Fresh blood collected with a 2-hour window, not after that. So within 2-hour window, you have to do the ESR testing, and before loading the ESR tube, you have to mix the tube 3 to 4 times. Place tube rack in a vertical position at room temperature. No bubbles in Winthrop or Western Green tube. Fill the tube up to the zero top. There should be no vibration free area, that is motionless. There will be no centrifuge, no things, nothing which can vibrate. It's going to change the result. Label accurately. That's why I always tell on the top of your tube, we have to place the label. Do not include Bapi code in results reading because you cannot see that much Bapi code. So you are not going to add the Bapi code. Do not include Bapi code in results reading. So this is the packed RBC. This is the Bapi code and this is the plasma. So where are you going to read it? You are going to read it beneath the Bapi code.
Hello, ma'am. Excuse me.
Yes.
Ma'am, can we have a break?
Yes, let me complete the ESR then. Okay.
Okay,
Just give
thank
me
you.
that.
Love that.
So, yeah. Asnet. Break.
Okay. What happened to you?
Yeah.
I'm here.
Yeah. So can you read and result this Winthrop ESR tube? How you can understand this one? What is the value here? You are going to read from the
It's
top,
there, ma'am.
right?
That's
You are
right.
going to, yeah. So what is going to say here? This is a
So
5, 6, 7, and
8.
8. So to discuss it. Only you can just give the value. Hematocrit you guys know now. We are going to go to the quality control and then point. This was also you did the Himaku. We are going to go through quick. Okay, just go because we have to complete the other one also. Okay. Okay.
Okay, ma'am.
Quality
Thank you.
control. Okay. Procedure. This we
What
already
time,
did the
Beth?
MITRE. Right now.
What time are we
10
back, Miss?
minutes. 10 minutes.
10 minutes?
Yes.
Okay.
Go half an hour.
Okay, thank
Okay,
you
thank
so
you,
much,
ma'am.
Miss.
Okay. Okay.
Okay,
Okay.
Thank you,
bye.
ma'am.
Okay. Okay. Okay.
Thank
Bye.
you, Mom.
Bye. 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 Enjoy. Attendance. Attendance. Laboratory skills. Richard, Tibash. Itu kecil jana. Anyway. Oh, is today everybody is present?
Here, ma'am. Present.
Yeah, okay. What's happening?
No,
Yeah,
sorry, it's Inho. Yeah, I'm here.
yeah, I know. I saw you.
Okay, thank you.
Welcome, no problem. Today's March 6, right? Yes. I sent you and forwarded you an email from Rajiv. So you guys got that one, right?
Yes, ma'am. The one you sent yesterday?
Yes, ma'am.
Yeah. Okay.
Yeah.
Yeah, Rajiv told me to do that, so that's why I sent you that one. Okay. Good.
Thank you.
Okay, you're welcome. No problem. What? Hi. This house. Babe. Okay, so let us start whatever's the left there. So you guys have already learned about the hematocrit. So generally hematocrit we do that is the ESR. Okay. Did my microphone is on or off? Oh, it's on. Okay. So hematocrit, we know already that we measured the packed cell volume. So how much the RBC got packed? This is the macroscopic observation because this is not under the microscope. In a sample of the, and how we measured it is the percentage of RBC in a total volume of whole blood. That's why you have to measure the, when you are measuring, you have to set the top from the plasma level. So it is used in evaluating and classifying various types of anemias according to the RBCs and BCs. Not only the anemias, that's not right. Also, there is any problem in the blood cell counts. So how you do the measurement? We can do manual and automated. Nowadays, hematocrit also automated. So specimens, you can take the EDTA whole blood or you can do the capillary puncture. Mitohematocrit significance in newborn is really high. Infant child is getting adjusted to the normal. Always male is higher. And in female is lower. It's just opposite to the ESR. We know fill 2 capillary tubes 3/4 full with blood. 3 parts will be filled with the blood. 1 part you can left EDT or capillary or till the up to the ring. Seal the tubes by plugging the dry end of the capillary tube with grit seal, dry end. Wipe the exterior of the capillary tube free of blood and place it in a small test tube labeled with the patient's name and specimen number so that you doesn't lose it, whose patient is, whose hematocrit tube is whom. So that's why you guys are placing after the sealing, you guys are keeping it there. So you guys are missing it. Whose hematocrit is that one? Generally, after seal, you have to put them in vertical position in a tube. Place the duplicate tubes in the mitohematocrit rotor. Make note of slot numbers. Which slot number you are putting yours, making sure the capillary tubes are balanced like any centrifuge. And how much this is, we are centrifuging 5 minutes for 14,500 RPM. I don't know what is your machine said there, 14,500 or 10,000?
It's 10.
10,000. Here is, what I know is 10,000. I don't know why this is 14,500 RPM. It said 10,000. That's I know. The separated RBCs from plasma and leaves a band of Bapykot, which is not visible basically, consisting of WBCs and platelets between them. Whenever you centrifuge any anticoagulant blood, you are going to get packed cell with the RBC, then a Bapykot, which is composed of what? In Bapykot, what we have?
WBC and platelets, ma'am.
WBC and platelet. And then we have the rest is the plasma. What is the proportion of the plasma and RBC?
45% for the red blood cells and 55 for the plasma.
Okay.
Right.
Okay. Very good. Generally 55% of the plasma, but 1% is the Bapykot. Generally it is so low they doesn't count. 1% generally is the Bapykot and this is the 54%. But as per your question answer, 45 RBC or packed cells and 55% is the plasma. So this is the packed cell volume of duplicate tubes using a mitohematocrit reader. Now you guys know what is hematocrit reader. Okay, so video in D2L for viewing, quality control. We always do the duplicate samples. That's why I always told run part of the quality control. Error must be within 1% or maximum 2%. Generally, all of you get the results within 1% error so far. Fresh samples are the best and it should be collected within 2 hours if you are collecting in the EDTA tube. If you are doing the capillary puncture, then you have to run it immediately. The capillary blood is used while first drop of away to avoid interstitial fluid. contamination would dilute out the sample. That you all know. Do not read Buffy code in packed cell volume reading. Generally, you cannot see the Buffy code, but don't, if you see even, read just below that one. Interference and sources of error. Incomplete sealing of capillary tube, it will be falsely low. Measuring Buffy code is going to give the high result. Forcing centrifuge to stop, falsely high. If you doesn't allow to spin in the proper rotation time or RPN up to proper time. Hemolyzed blood samples give you the low, obviously, because the RBCs are going to lyse. Patient is dehydrated, high. If the patient is dehydrated, that means it's going to be more concentrated. Abnormal red cell morphology present, falsely high. If it is the high macrocytes and other things, it can give you the, these are not that much needed. You can just mainly the anemia and tubes sitting 15 minutes or longer before reading. Okay, so unreliable. If you are leaving the tubes after centrifuge for more than 15 minutes, is going to be, you have to recentrifuge again. Then you have the POC, point of care testing. What is point of care testing? It is
Beside the patient.
beside the patient. Very good. Very good. Beside the patient. So you already use the HemaQ. It's easy. Point of care testing. You do the hemoglobin measures laboratory. So you take the EDTA sample or you can do your capillary puncture on a CBC analyzer. There is in the CBC analyzers, they give all the hemoglobins and everything counts. But if you have to do it immediately on the patient side, so you have to use the point of care testing instrument. That is the HemaQ. Hemoglobin determination is called the HemaQ method. Good for where access to an analyzer is limited, or sometimes the analyzer take some time to analyze the samples. The HemaQ give you the immediate answer. It is a photometer. It sends the light. Light absorbance is read at 570 nanometer and 880 nanometer. Generally, this question doesn't come, but this is, they use the light, wavelength of light. What wavelength of light? Because hemoglobin is there and 570 and 880 nanometer. HemaQ is a handheld. What is the handheld POC? This is the hemoglobin, the HemaQ, and also the glucometer when you use the glucose. Handheld POC device used to measure hemoglobin concentration. Collect 10 microliter of capillary blood using microcuvette. So microcuvette has sodium dioxalate, sodium nitrate, sodium azide. You doesn't need to know all these things. So sodium dioxalate, what that? It hemolyzes RBC to release hemoglobin. And sodium nitrate convert hemoglobin into methemoglobin, because ultimately they are going to read the methemoglobin, and finally convert methemoglobin into the hemoglobinazide. You doesn't need to know that one. So basically, HemaQ is used for the point of care testing. It uses the wavelengths of the light. It is a photosensitive method. You doesn't need to remember it's a photosensitive method. It measures the hemoglobin concentration using the light source, and keep sealed container to avoid decay of reagents. Forget it. Put samples in the HemaQ within 10 minutes of collecting. So immediately you have to do the test and result will display in the 45 seconds. Any questions? We are all done for this one. What is next one? The automated analyzer, CBC history. Huge. How many slides are there? 52. Okay, let me see one thing. What is next? Hema. After this one, how many we have? Unit 2, Unit 3, manual testing procedure. Unit 3. So this is the Unit 3. Then we have Unit 3. Read this one, Unit 3. It's late. This one I did already, right? Identify the cell function. Okay, so this you guys have to do this one. This one I did, okay. PowerPoint. Complete. Unit 4 and 5. We are Unit 2. Unit 2. Unit 2. Identify cells. Function of the cell. That is, you have to do the function of the cell web page, identify the cells. That is, you have to do. These are you guys have to do, okay? So we have already read this one, identify the cells. That is your web page. I showed you that you have to do that one. Okay, so you have to answer this one. You guys can have this one now. Okay, so then that one. Oh dear, whenever I'm going there, is okay. So okay, so 4 and 5, Unit 3. It's going to be jumping to Unit 4 and 5. I don't understand.
Ma'am, excuse me. I just
Yes.
want to ask. Ma'am, for the activities that you want us to answer, is that also part of our marks or grades?
Yes.
Or
yes.
just for review? Oh.
No,
okay.
no. You can see there is 13 questions. Mean there is a percentage of mark from there. Okay.
Okay, ma'am.
So
Thank you.
complete blood count. We see this one. Complete blood count over here. Testing procedures. Peripheral blood similar manual hematokit also within. But where is the automated cell counter go? Hematology. Then it did, right? Manual hematokit, hemoglobin. Okay, so this is hemoglobin.
So to start with the microhematocrit, we have our equipment here, Kim wipes, a mixed tube of blood. That's
You need to see this one.
A capillary tube, sorry. We've got our rack here that we can put our tube of blood in after we finished with it. This is our microhematocrit centrifuge. You can see it has a max time limit of 5 minutes. This is 1 minute, 2 minutes, 3 minutes, 4 minutes, and all the way up to the top here would be 5 minutes. This centrifuge rotates at about 8,000 RPM. And for a microhematocrit or manual hematocrit, we would be running it for the full 5 minutes at that 8,000 RPM.
That's not right, though.
We also have our clay seal. This is what we're going to be using once we load our capillary tube with our patient's blood, just so that we would have a really nice seal on the dry end of the capillary tube. To get our centrifuge ready, we can see here that we're in an open position because the line is going this direction versus lock, which would be upright. So we can actually just pull this right off, and I just want to show you these parts here.
Oh, this is very old
We've got
type.
3 sections on this spot where a capillary tube can sit, and we've got 3 sections over here. Now we run 2 on the same patient, and that's a quality control way of monitoring our quality control. So we can be plus or minus 1% out, and that is our tolerance error for this procedure. So writing our patient information on our worksheet is really helpful because we can't label our capillary tubes because they're too small. So we can take our patient information directly off the primary label, and we're going to indicate which positions in this rotor we are going to be putting our sample. So for this instance, I'll be using section 2 and section 5. So I can write position 2 and 5, and then I'd write the patient's name. I like to put in the accession number right here, which is your year, your Julian date, and then the number for the actual day for that specimen. This is because this is a manual test, and we will have to enter this into the LIS ourselves. So it's great just to have our accession number right there. And then once we get our results, we'll put that there and we'll initial it to result. So now we need to be filling our capillary tube with our specimen. And of course, we'd always double check that we're working with the proper specimen, looking at our label. And then as we open it up here, let's prevent any aerosols by using our Kim wipe. And we can grab a capillary tube. Now this capillary tube draws up blood, and it uses via capillary action. So all we have to do is kind of introduce the tube in the capillary tube into the primary blood tube and turn that primary blood tube there, and it's just going to pull it up. Okay, we want to fill this about 3/4 full. Keep it nice and straight horizontal because there is a hole on this end and there's a hole on this end. So if you turn it, put it vertical, you will lose all of your blood out that direction. So you can see here, I filled it about 3/4 full. I know I'm a little bit close. There we go, 3/4 full. Now I don't want any of the exterior blood to contaminate my machine, so I'm just going to wipe it off this way. We would never touch this end because that would draw this blood out the other direction. We want to cap the dry end, which is where my fingers are holding, with some clay. So if you're quick enough, you can vertically put it into the clay, or if not, you can bring your clay up to your specimen. And there you go. We have that clay end right there. Okay, now I can pop that into my instrument like so. I don't know if this is going to be weird for me doing this. I'm going to put that in spot 5 and make sure it's nice and settled in spot 5. We need to do a duplicate. So you can see here I have one on spot 5 and I have a duplicate on spot 2, and that's our quality control again. Remember, we need these 2 values to be within 1% of each other for this test to be valid. So we're going to close this up. Make sure it's in there. Close it up using our little bit hard. I'm going to use 2 hands for this. There we go. So now we have that upright in the lock position, and we can close the lid. Make sure it latches on the bottom right here. And we're going to put it up to 5 minutes. 8,000 RPM at 5 minutes, everybody.
Not 8,000 though.
So our centrifuge is just coming down right now, and we're going to wait for it to stop before we open it. There's no high-tech gadgets here that would stop us from opening it, but of course for safety purpose we would. Now, just like any centrifuge, we do have glass tubes rotating inside, and if one breaks, we would still follow that same procedure of let it sit for 30 minutes, have a sign warning anybody else from opening up this centrifuge for those 30 minutes, and we could take this to a biosafety cabinet and we can open it up there and properly disinfect it. So right now, let's just take a look. We're going to open this up. We're going to see what we have here. So we have a naturally spun tube, right? Look at that. We've got our pack cells down here. We've got our little buffy coat, and we've got our plasma up here. And we've got one on the other side as well. Okay, so we can use this to read. However, it's a little bit old, and I'm not so sure how accurate it is. But just for example, let's see if these are within 1 or 1% of each other. So if we read this through our microscope here, we could see that it's at about 36% or 0.36 liter per liter. If we look at this one, we can see as well, it's about 35 and a half. So 0.35 or 35%. So they are within that 1%. Now, another way of reading is to use this microhematocrit reader right here. Now, when we have our tube, all we do is we place it in the groove here. And all of the instructions are right here. So if you follow along, we should be able to get a good value. Now, this might differ from the value here, but what the main thing is to use whatever measuring technique is used in your clinical lab environment, whatever the procedure is, and that you're standardizing that measuring. So let's see here. So we placed our capillary tube into the groove, and we lined at the bottom of the packed cells with the line on the holder. So that's talking about this red line right here. So if we do this, we've lined that up with the holder, okay? We want to grasp the lower end of the plastic holder and move to the right or left until the top of the plasma is in the tube coincides with the 100% top line. So that would be this 100% line right here. So we need to find out where our plasma ends, and our plasma ends right here. So we move this all the way over till it coincides with that 100% line. Move the knob at the end of the reader bar, that would be this guy right here, until the line on the reader bar coincides with the line separating the packed cells from the plasma. We are not going to be reading a Buffy coat. If you have a high Buffy coat, you will not be reading that because we're only interested in the packed red cells. Okay, so as we raise this little knob up, you can see that that line is moving. And we're going to move it right till we get right there at our red cells. Okay, this one is kind of hard to see the Buffy coat, so we're just going to put it right there. And now we're going to read the percentage of packed cells in the window. So it looks like we've got a 0.444 or 0.445. We're right in between there. Okay, so we could, I'm not sure if we round that down to 0.44 or 0.45. I don't think it really matters, but what matters is that we have our two samples within that 1 or 2%. So if we pop our second sample on here, and we line that up the same way we did there. And let's see our plasma line. We've got to move that a little bit. There we go. Okay. And then we adjust this right up there. Where are we at? 0.44. So we are within that 1%. So we have a really great result here that we can verify. Now, like I said, whichever one you use, I know your textbook says, your lab manual says to use this one. So this is the one I'm going to use, and we're going to come over here, and we're going to result our patient if my pen worked, it would say 0.44, my initials, and no comments because both sides matched within 1%. So we could even say that as a comment, as a quality control comment. Okay, so that is the microhematocrit.
This is also your homework, okay? You have to write down what is what from the slide. What is perfect, what is short, what is streak, what is the pad the plate, where the smear is not uniformly distributed from thick to thin, when it has been crossed the edge, and this is the streak, this is too thin, this is not properly done. So you have to write it down from the PowerPoint. This is your answer key, okay? So you have to write it down. This is also your work, homework. Okay, next. What is that?
Miss,
Yes.
we're
Tell
not going
me.
to have any time for supper. There's so much homework today. We're not going to have any time for supper.
Don't eat. You will lose some weight. That's good for you. Good for you. People are striving for getting, zero figure.
Oh Lord.
So we have all the slides here. So automated analyzer, where is the automated analyzer? I just like to see that one. Okay. So you guys can start doing right now. It's 12:19 now. You have a lot of time to do that one. You do your homework, okay? You start your homework. There will be 40 minutes. You can do it. It's going to be easy one. And
So
Yes,
let me
ma'am,
ma'am.
we have 4 activities to finish, right?
Yeah, just do it. It doesn't going to take too much time. All activities are
Okay.
very small. Just do it now.
Okay, ma'am.
Oh, this is unit 4 and 5. Okay. So that is a different one. Unit 4 and 5 we can go tomorrow. Okay. Okay. So you all can complete all the videos, all the assessment. I'm going to go to the unit 4 and 5 tomorrow, okay? So that you guys have enough time for today to complete all the things.
Yes, ma'am. Thank you.
Okay.
Yes, thank you.
Thank you.
Welcome. Sasnet is not going to lose the supper.
No, I won't. I'm driving right now, so
So you are not ready.
after reach home, I gotta do. I'll do
Okay.
it tonight. Thank you, Miss Mama.
Okay, no problem. Um, two, 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 two.
Miss, I'm having trouble trying to find the homework we have to complete today. Do I find it under assignments or?
You go to the D2L.
Yes, I'm in D2L.
It's under Unit 1, Santiago.
In what? In content?
Hematology, Unit 1.
Oh, okay. Over where content is. Okay. All right. Thank you.
Thank you.
Welcome.
Excuse me, please.
Who is cooking? Not doing the homework with this time? I gave you the time to do the homework so that you can cook later and have good food.
Huh? Yeah.
Yes.
Is it on that quiz they identify the cell function? Or?
Okay. Dear, you can talk to your classmates. I had showed you all from the beginning. You have to follow that one, dear. You can ask any one of your classmates. They can give from their side. It's going to be easy. Because my side, I am doing the teacher's things. Anyone can help Rugiato sharing your screen so that she can understand.
Guys, which one is the right one, please?
Huh? Is anyone is ready to help Rugiato?
Sorry, miss. I also have the trouble with the task. I'm go to the unit 1 and at the student tasks page. Is that the right page?
No,
Sorry.
it's not Yang Hong. You go to hematology, scroll up to the bottom. Chapter 1 in hematology. Scroll to the bottom and you will see the parts of the heart. I'm still on the parts of the heart.
Yeah, parts of the heart.
Parts of the heart and the flow.
Yeah, just scroll down and look for that parts of the heart quiz. It says quiz.
So you can see the screen. I showed you in the morning. You have to pay attention. When I show something, you doesn't pay the attention. That's the problem. So
You
this
can
is
see the
unit
screen
1
of
and
Miss
P.
Munyan. There.
Huh? You cannot
Yeah,
see my screen?
Yes, I can see it.
So I showed you. So you are going to click. I showed you in the morning. You doesn't get the pay attention. This is the hematology unit 1, A and P. And then if you go there, then you see down level heart activity, path of blood activity. Okay. So then you are going to move forward to the unit number 2 and then you can see the other things. Got it?
Okay, so it's part of the blood activity, right? Because I've already done the label the heart.
You already labeled the heart?
Yes.
Submit it?
Yeah.
So it said quiz, okay? So
Yes.
preview, go to preview, and then you have to start the quiz, okay? When you start the quiz, then it's going to show this one and going to tell you, identify the structure labeled in 5. What is that? Your answer is here. You have to write there. Then you have to go to the next. You have already done that? That's fine then. Okay, so then you have to go to the next path.
Yeah, I want to know the next part. That's what I'm asking.
Okay, so just go to the next part. Why is not coming here? Until you complete this one, it doesn't submit quiz. Okay, then it's going to tell you. Okay. It's going to. Submit quiz because I don't need to submit quiz. So my quiz has been submitted. Oh. I have to go to the again the heart activity. Return to content. Okay. So then we are going back here again. So return to content. Why is not taking me to the content? Okay, so if you just go there, that is going to show you. This is
Blood
the,
is important. We need it to live. Hey, this is Leslie Samuel from Interactive Biology TV, where we're making biology fun and
oh, you have to go to the here, so it's my problem. Okay, so you need number 1. Okay, so again, if you go in the top, you need number 1, and then can see the next path of blood activity after the label heart activity. Okay,
Okay.
got it? Okay.
Yeah.
So then you are going to the unit number 2, and there you have the other things to do that same way. So you need number
okay.
2. Okay, so you need number 2, identify the function of the cell, identify the cells. Okay.
Okay.
Okay, got it?
Okay.
Okay.
Thank you. Yeah.
Okay. Okay. Another 10 minutes.
Hello, ma'am. Ma'am, are you there?
Okay, dear. See you tomorrow. Okay.
Bye, Miss.
Have a good
Thank you.
afternoon. Okay.
You too.
Yeah.
Yes,
Yeah.
ma'am. Bye.
Yeah. Bye. I'm going to see a doctor now. Okay. Bye. Bye. Bye.
Okay,
Okay,
ma'am.
ma'am.
Bye.
Thank
Bye,
you.
everyone. See you
Bye.
tomorrow.
Bye.
Bye.
Thank you.